G'day everyone. Today we're going to continue our series on airway management with a specific focus on ventilation. The key take-home points from today are going to be an obstructive strategy towards ventilation. Firstly, what it is, and secondly, how we achieve it using volume control. But first, let's do a recap on some of the key points we've covered previously. We've been talking a lot about intubation and how to go about doing it. We had a little mnemonic called the 5 Ps, which helps structure our thoughts towards intubating a patient. First, we prepared. We got our equipment together and we used the SOAP me mnemonic to remember that. And we also assembled the appropriate personnel to safely manage the airway. We pre-oxygenated our patient. If they were ventilating appropriately, we stuck standard nasal prongs on and a non-rebreather mask, and we cranked them both to 15 litres per minute. If they weren't ventilating appropriately themselves, or if they had gunk in their lungs, we chucked on a bag mask and a PEEP valve, and we supported their ventilation and added some PEEP onto that. We positioned the patient, and basically anything other than completely flat is what we're aiming for. In that spontaneously ventilating patient, we're happy to keep them upright until the act of putting the tube goes in. In someone we need to bag and mask, we wouldn't want them any flatter than 20 degrees head up. We expertly placed the tube, and then we moved on to the post-intubation management phase, and that's what we're going to talk more about today. Again, we'll review some of the brief airway assessment that we did pertaining to intubation. First, we looked at the airway, and the 3 things that we wanted to pay attention to were a thick neck, a small mouth, and a receding mandible. We evaluated using the 3-3-2 rule, so we wanted the patient to have at least 3 finger breadths of mouth opening. We wanted to be able to fit 3 fingers between their hyoid bone and the tip of their chin. And we also wanted to get 2 fingers between the top of the thyroid cartilage and the hyoid bone on the base of the neck. Mallampati score is something to be aware of, but it's not particularly useful in the emergency airways that we manage in the ED. And we wanted to consider airway obstruction separately. This includes things like trauma to the airway with upper airway injury, and also inflammatory and infective pathology like Ludwig's angina or angioedema. These pathologies and airway management of them is the domain of our anaesthetic colleagues, the airway experts. Lastly, we paid attention to the neck and how mobile it was. We want patients to have good neck extension to be able to get into that sniffing of the air position. So any patient who's in C-spine precautions is instantly a difficult airway. And so those were the components of our lemon mnemonic. Now, we've been talking about 2 types of ventilation strategies. Firstly, we touched on the lung protective strategy. Pathologies which require this include things like pneumonia, ARDS, basically anything in which gunk fills the alveoli. The second strategy we talked about was the obstructive strategy, and that's what we'll elaborate on today. Pathologies which mandate this strategy include COPD and asthma. The principle here is that small airways are constricted and limiting the flow of air out of the lungs. We wanted to be able to execute these strategies using volume control. And we considered 4 parameters which were in our control. They were the tidal volume, the respiratory rate, and also the IA ratio, the FiO2, and PEEP. Now, with our lung protective strategies, we talked about what we would initially set. We wanted a relatively low tidal volume, 6 to 8 mils per kilo. A respiratory rate of 16 to 18 is appropriate to start with an IA ratio of 1 to 2. Our FiO2 and PEEP are intrinsically linked, and we use FiO2 PEEP tables to titrate these. The general principle is we want to be generous with our PEEP and we want to limit the FiO2 to which we expose our patient. Now let's look at a very crude animation that demonstrates what the main problem is in those patients who have gunk in their alveoli. Essentially, the gunk in the alveoli is making it more difficult for the oxygen to diffuse into the red cells in the pulmonary capillaries. Now, let's look at an even cruder animation of what's going on in those patients with constricted small airways. What's happening is that the air is struggling to get out of those small constricted airways. Remember, exhalation is a passive process, and the ventilated patient is getting air forced into their lungs at high flow rates during inspiration. The consequence of that is a process called dynamic hyperinflation if there's not adequate time for the lungs to empty during exhalation. So what do we do in an obstructive strategy? We need to set 4 things. Tidal volume, let's choose 8 mils per kilo. Our respiratory rate is lower. Let's go with 10. That means that the respiratory cycle is 6 seconds. So we choose an IE ratio of 1 to 5 to start with, hoping that that's enough time for all the air that's been forced in during expiration to exit the alveoli during expiration. We can start with an FiO2 of 1, and in the obstructive strategy, we don't want to be too generous on our PEEP, so we'll start low with 5 centimetres of water. So, what do we want to take home? We want to remember that there are 2 types of ventilation strategies for 2 separate types of pathologies. Pneumonia and ARDS are the prototypical gunk in the alveoli pathologies. These are the patients in whom we use the lung protective strategy. Obstructive strategy is required for patients with COPD and asthma. These patients have constricted small airways which limit the movement of air out of the lungs passively. Oops, there we go again. And that's it. Thanks for watching.